listening to the Massage Therapist Development Initiative. I'm Jamie Johnston.
And I am Eric Purvis. This is a podcast by massage therapists for massage therapists.
Our objective is to simplify how to be a more evidence-informed practitioner. Let's dig into this episode. Sometimes things in our profession change, sometimes for the better, sometimes for the worse, and sometimes we're not sure if it's for the better or the worse. This is one of those instances where I know that this is instituted with other colleges, but for our college in British Columbia, they have come out with a new standards of practice for us, where we don't necessarily have to take a continuing education course for credit, but they have sort of laid the onus on us, and they've come up with career span competencies that we look at for us to decide which direction we would like to take our own practice. If that's the right way to say it.
I think that's very right. I have mixed feelings about this, and there's a lot of goodness, but there's also a lot of stuff that makes me concerned. And I think we should probably start off by saying our bias is that as people that earn a living teaching Con Ed and providing educational opportunities to massage therapists, we do get a lot of people that take courses just because they need the credits.
Yeah.
And they don't necessarily really care what the course is. They maybe aren't that engaged with the material. I would say this is a minority of people, but this does happen. And you always see, and I've been doing this since 2015, and you always see near the end of the cycle, you get a massive rush of people that are desperate for credits. And then oftentimes when you ask them, they're just like, well, this was available.
And it was the closest one to me.
It was the closest one to me before we had online stuff. So people would do that. And so from a financial perspective and from a business perspective, the old system was good, but it also, I think you'd probably agree that it was not always, that you wouldn't always get a full room of desire of people that really wanted to be there, that were really engaged. You'd have some people that are just like, I just need the credits.
Yeah. And that's, even if I'm teaching a first aid course, it's the same thing. It's, you try to make the class fun and make it so that people walk away going, okay, that was a fun class, but the biggest reason they're there is because the college just said you have to take it.
Yes.
Right. So,
and it's important for us to have these what they call this career span competencies, or what do they call it? They call it the Professional Practice Development Program is what they're calling it, the PDP, the Practice Development Program, which looks very similar to Ontario's Strive program, where it's basically more of a self-reflective, self-directed learning plan, which you create yourself, and you basically have to follow these kind of 15 what do they call them, career span competencies, and we'll talk about those I think individually here in a minute. They basically have to follow those, and you have to basically create a learning plan that meets those competencies that are relevant to you, which I really like, because I think if you as a clinician, and so as someone who still needs to take CEs, even though we teach them, we also have to take them ourselves. It can be very difficult to find stuff that is interesting or relevant to you,
or that you want to take.
Yeah. And so I think this actually is good. So, okay, the negative is from a business perspective, like it's easy to sell courses when there's minimum CECs.
Yeah.
This is good though, in the fact that it gives RMTs the ability to choose and pick the kind of the direction they want to go based on their interests and based on where they are in their career and based on the populations they treat or the environments they work in. That is good. And I'm not going to dispute that. I think that's good. I'm very curious though about how this is going to be adopted by the profession.
Yeah, it's more in this case of a practitioner benefit, which is great. Yes. Right? Because this way you get to decide where you want your career to go, which is we should all have that autonomy within our career to be able to say, I know we're not allowed to say that we specialize in something, but this is the things I want to focus on in my career. These are the directions that I want to go. And they're giving you the leeway to say, good, then go do that.
Yeah.
Which is great. But I think it's important, and I don't know if we're going to talk about it later now, but I'll bring it up now. It's important for us to take into account that they're giving you that leeway and giving you the benefit of the doubt that you're actually going to do it. So we've seen some debate, for lack of a better term, in some of the Facebook groups where people are like, great, I don't have to take CECs now. That's not what they're saying. And by saying that, you're actually almost like kicking dirt in their face, because with them doing it this way, they've taken a step back and went, we're giving you the benefit of the doubt. We're giving you some leeway for you to decide which direction you want to go. It doesn't mean you don't have to not take courses. So they're putting their faith in you that you're going to be a professional and say, okay, I'm going to keep up with this, and I'm going to make sure that I'm as highly educated as I can be in my career in order to be of best benefit to my patients, which is the college's job, is to protect those patients. So they're now giving you the benefit of the doubt that you're going to do everything you can for the benefit of those people.
Yes. Yeah. And I think the only difference with this is you don't have a minimum number of credits to take. You don't have to go through the approval process, which I must admit, like, right, it's kind of annoying as you have to submit all this paperwork and fill out all this stuff every time for a course. It's kind of a pain in the butt. So now people can pick and choose what they want. And they don't have to worry about going through that process. The worry though I do have with this is the college was going towards their evidence-informed practice thing.
Yeah, which was good.
Which was moving in the right direction, even though stuff that wasn't, and this might be another podcast, stuff that wasn't evidence-based or evidence-informed was still getting pushed and being called evidence-informed and being approved. So I would say the approval process for that was probably not as stringent as it should have been. But they were moving in the right direction. Now they're doing this and they're saying, we trust you to come up with stuff yourself, but without an approval process, how is this ensuring that people are going to learn stuff that's relevant?
Yeah.
Or learn stuff that is science-based or evidence-based or stuff that is defensible with current research. And that is where I get a little bit kind of concerned, so to speak, like, well, how is this going to be implemented, or how are people going to adopt this into their practice? And I don't know enough about Ontario's program. It's been around for longer.
I think a few years. It hasn't been around like a super long time, I don't think.
No, but maybe 3 or 4 years longer than like previously. And they used to have a minimum, like a CEC requirement as well. And now they have more freedom. The freedom is good because it allows us to choose, but it does, I think the problem it results in is I think it can potentially allow more of the pseudoscience, more of the undefensible or non-evidence-based stuff to flourish, because now that stuff doesn't have to be approved.
Yeah.
So I'm kind of stuck in this. I'm not really sure how to feel about it yet until I see it in action.
Yeah, I agree. And especially like, when we look at the list of things, sorry, I'm just going to bring it up again here.
Of course.
I mean, the topics that they give that we have to meet up to are great. Maintaining a safe work environment, maintain comprehensive records, manage time and resources effectively, treat others respectfully, use evidence-informed approach in your work, interact effectively with other professionals, like all great things that we should be focused on within our continuing education. But not a lot of those are instances where there's courses offered on them, which is probably why they've developed some of those courses that we have to take, which is fine. But when we look at some of the other ones, like functioning in a patient-centered manner, we should all be for patient-centered care. But to go back to the point that you were talking about, we see a lot of other comments and a lot of other terminology that's used that isn't patient-centered, that is still being pushed as a narrative that we should use with patients. So there comes back to that concern about whether those things are going to be approved for people to take courses that aren't patient-centered, essentially.
Yeah. And I agree that there's, you look at this, the 15 CSEs, and I don't know, do we want to read them all? We don't have to read them all. I think we'll read the ones that are the ones out that are probably most relevant. You said the first one here was function in a patient-centered manner. Mm-hmm. Right. And that's a good one. So working in the best interest of the patients. And so the brief descriptor here is, I won't read the whole thing. It says, you ensure that patient well-being is at the center of the decisions you make and are aware of your obligations to safeguard young persons and vulnerable adults. Okay, that makes sense, right? That's That should be
Yeah.
just a given, right? You give each patient your complete attention and allow sufficient time to fully address their needs. You respect patient uniqueness and take into account their views, preferences, and concerns, which is great, right? So when people come in, they tell us what their issues and concerns are, and then we try our best to help them within our scope of practice.
Yeah.
You actively involve patients in decision making and ensure that they're fully informed about and consent to the services you provide, which is great because so people come in, we give them information, we allow them to make decisions based on our own. But the problem with this, and I think you and I have talked about this before, if we haven't talked about it in the podcast, we definitely talk about it almost every time when we teach, is patients are fully informed about and consent to the services you provide.
Yeah. And
I don't know if you want to expand on that, because I know you have a great little spiel about this, is that, but if we're giving them information that's not evidence-based, that's based on beliefs or historical ideas, but not based on current science, is that informed consent? Are we giving them proper information to allow them to make decisions about their healthcare?
It's not. Right. So as long as we're stuck to many of those old narratives that we learned in school that have since been proven wrong, if we're still relying on that. And I think a perfect example was, and I don't know who the person was, so I'm not, trying to put them out or out them in any way. But when we went to the RMCDC conference a couple of years ago, that was based around cancer. And the person stood up and said that they had been a therapist for 25 years and they were shocked that we were allowed to treat people with cancer. So in 25 years, this person had taken, I don't know what, for continuing education, but had not gotten past the fact that cancer wasn't a contraindication anymore. At least parts of cancer weren't a contraindication anymore, and was baffled that it was okay to give somebody with cancer a massage, when we know now that's like one of the best things we can do to help them. So for whatever courses that person had taken in 25 years, had obviously not been given enough updated information to understand that. So I would make maybe a bad assumption that they're probably still using techniques and narratives that were based 25 years before. And so if you're doing that, you're not getting informed consent from your patients, because you're still telling them that you're unwinding their fascia, or you're, altering their craniosacral rhythm, or any of these other things that we learned that we know aren't true.
Increasing circulation and therefore spreading cancer, or putting too much load on the heart, that kind of stuff, which we know has no science behind it.
That you're increasing the risk of a diabetic reaction with a massage.
Right.
Like there's so many of those, right? So if you're still using those outdated narratives, then you're not getting informed consent from your patient, because none of those things are real.
Yeah.
So that, it's, depending on what the courses people are going to be taking are. And the more that we talk about patient-centered care, we see in many of these forums, people use a number of other, I don't want to say it's a description, many other terminologies to try to represent the same thing. And one of the ones that I see that I never really understood was heart-centered care. And then I Googled it. And if you look at the definition of heart-centered care, so I literally Googled heart-centered definition. It says being heart-centered means that you are aware of what you desire in life. You know your values. You know how to take responsibility for yourself and your emotions. You make choices that honor your needs, values, and beliefs. No point does that say anything about a patient and collaborating on what you're doing with them. It's everything in there is you. So if you're going in and saying that you're providing heart-centered care, it has nothing to do with the patient.
It's clinician-centered.
Yeah.
Yeah.
Which is the exact opposite of what the college is requiring of us.
And that's a term too that I've seen floating around a bit, and people grasp onto it because it sounds very holistic and very great. But
I'm sure the intent is
probably in the right place. But I agree with you that if we are wanting to be a science-based mainstream musculoskeletal profession.
Mhm.
That, and we've said this before, I'm going to say it many times, that we definitely have the capabilities of being leaders in the treatment and management of any musculoskeletal thing, for the most part. When we're making up terms or developing new terms about stuff and trying to like come up with our own acronyms, our own explanations that have no scientific basis,
Yeah.
that's not serving our profession or the public's best interest.
No. And
But we see that all the time.
we have to keep in mind that the college's responsibility is to protect the public's best interest.
Yes.
And they're goes back to they're putting their faith in you that you're going to do the right thing by them developing things this way.
Yeah.
So, but then it also goes back to like how closely is it going to be monitored as to what course you're taking or what you're doing.
Right.
So we'll see how that develops as this goes on, and hopefully they do a good job of making it so that therapists are taken to task for what they're taking, what courses they're taking.
Yeah, and that's the one thing that worries me too, is they say all these words, but they're very vague. Nothing is really very specific.
Mhm.
And so how is the college going to, like, what are the metrics for that? How is the college going to know if someone is fulfilling that or not when you don't have, like, you're just like, the person's going to work in a patient-centered manner. What's that mean?
Yeah.
Without the college really providing specific definitions, or without the schools teaching that specifically, it makes me think that's up to so much interpretation,
Mhm.
which is good, that there shouldn't necessarily be these hard and fast rules. But it also, I think, can allow for a lot of like really pushing boundaries of what that means.
Yeah.
Like you said, like heart-centered.
Yeah.
You know, that's not even a thing.
Yeah. Yeah. At least provide a guideline of some sort.
Yeah.
To say this is what we expect.
Yeah.
And this isn't going to be implemented until January, so those things could still come out in the meantime.
Yeah, I think the college did say that they are going to put out more kind of FAQs and more information about it. But this is just what we have to work off. So we're just making judgments based on, you know, our initial reactions. Yeah. One of the other ones too, which I think would be worth talking about. Like, there's a lot of good stuff in here, right? Maintain a safe work environment, maintain comprehensive records, personal wellness, you know, treat others respectfully. Like, yeah, that just makes sense. It's like, that shouldn't even be on here almost, because that should just be given.
That's common sense.
It should be common sense. That should be like, we all do that anyway. But this one here, what I thought was interesting, and it says, practice in a manner consistent with current developments in the profession. You take regular active steps to keep your knowledge and skills up to date. This includes reading professional literature, attending conferences, participating in courses and workshops, and consulting with colleagues. And this one, to me, is one of the ones I like the most.
Yeah.
However, how this is interpreted and how this is applied into practice or into someone's learning plan could be the problem. If someone is embedded to a technique, embraces a technique, or they view themselves through a specific like acronym or through a specific gist as the population of people I treat, and you have somebody you've taken all of their levels of their courses. Is that consistent with the current development in the profession?
Not if they're still teaching outdated things.
Yeah, and so that's where I think, okay, so what is current developments, and how do you know, or how is the college going to decide what is the current development? I would read that and be like, what's the current science say? So use the cancer example.
Yeah,
we can massage people that have cancer. Mm-hmm. Whether they are currently undergoing cancer treatments, or whether they are palliative, or whether they've fully recovered and they've got, you know, scarring and surgery or neuropathies after, we can treat those people and we're not going to increase their risk of harm. Mm-hmm. Harm meaning physical harm. However, using that cancer example, what if we start pathologizing, and say you've taken some, I don't know, some courses on cancer, on oncology, and those courses are taught with a non-science informed or non-science-based framework.
Yep.
And you're treating people based on that framework, and that might not be in the person's best interest, but that might be what you learned in the course. You maybe thought the instructor was great, maybe thought the course was great, maybe you had some great colleagues in there, but maybe the information wasn't based on current science.
But you were led to believe it was.
But you were led to believe it was. That's inconsistent with current developments in the profession.
Yeah. Yeah. It's almost too bad that there isn't something in there that talks about critical thinking.
That's I'm so glad because I was thinking that too. I read this. Like, this has nothing in here about engaging in logical fallacies or critical thinking or any of that stuff.
Reading, like, being able to, let's just going back to the cancer example, that if you look at like the new clinical guidelines on, say, cancer care and MSK pain,
Yeah.
I'm sure there's a paper out there on it. I'm sure I have it somewhere because I'm putting a course together on that. And then being able to go, okay, well, that's the creme de la creme. Those are the papers I should look at. And then you go take a course that has a whole bunch of case studies in it that have been refuted by the clinical practice guidelines.
Yes.
But the person teaching the course presents all these papers and says, no, look, it's based on research because here's the papers. We need to develop something to be able for therapists to critically look at that and go, okay, this isn't based on the best research. So maybe I should go home and look at some of that now and see if that refutes what I just learned in this course.
Yeah. And you do get a lot of that in our profession. We'll pick on our profession, but not just us, but you do get a lot of that where there's these anecdotal stories that are being sold as hard science. Yeah. And if we look at the evidence-based framework of like your clinical experience, your personal experience is part of that. And you don't want to refute that because you treat somebody and they get better and you do that numerous times and you see consistent results, and that's part of your evidence.
Yeah.
But the problem is the reasons for why they might get better might be very different from what you think.
Absolutely.
And maybe what you're doing and the stories that you're putting on some of these people and these beliefs that you're putting onto them might be harmful because it might take away their autonomy or their self-efficacy. Mm-hmm. That is, I think, where why it's important for us to be mindful of the difference between using anecdotal stories to validate why it is you're doing what you're doing versus the science, because the science is there to inform those anecdotes.
Exactly.
I think. I don't know if that's right, if I said that right, but that's how I see it. So say that again. I think you cut out.
And why that anecdote worked.
Yeah.
Right. And that all comes back to the second point in their thing is communicating effectively.
Yes.
Right. So being able to take the current science and communicate that effectively to a patient, so that these things aren't happening, so that we aren't just using this anecdotal evidence and saying, yes, it's because of XYZ when it's actually because of ABC.
Yeah. And that's not pain-splaining.
No.
Or not science-splaining. I think that's sometimes too, when we think about effective communication, people are like, well, how do I explain pain to people? Or how do I explain this dysfunction? Or how do I explain this disease to people? And we just kind of like vomit information people. That's not what it's saying. No. So I think that's part of effective communication is communicating at a level that people want, as well as our own knowledge, like how well can we communicate and how much of that information do they need and how is it received? And I think they do say a thing in here too, you communicate clearly and concisely as possible and take steps to ensure that you are understood. That's a really important piece. Ensure that you are understood, which comes down to asking them if they've understood or asking them to repeat it back to you.
Yeah. There's that old thing of like, okay, so tell it back to me like you were explaining it to a 10-year-old.
Yeah, exactly.
Right. So that you get whether they absolutely understand what you were saying, because if they repeat it back and it's not at all what your intent was, then you need to change that communication and correct it before moving on with your treatment and all that. And that's all part of that consent thing as well.
Yeah.
Right. And I like what they put in there is like even reading nonverbal cues, reading body language, things like that. So that, if you're saying something to somebody, because I know there's been plenty of times in my career where I've stuck my foot in my mouth and you see the person kind of looking at you and being able to read that patient and go, okay, I need to take a step back here because I either said something wrong or said something they misunderstood and are not taking the way I intended. So there's a whole bit more behind that, but communicating effectively is obviously going to be an important part of what we do.
Yeah. I think a lot of the stuff comes back to that effective communication.
Yeah. Well, especially when we look at the clinical guidelines of like the best approach for MSK care is always that reassurance education, right? Those two first things are all about communication.
Yeah.
And there's a reason that the importance of those things are number one and two, and then movement and actual manual therapy are three and four.
Yeah.
Those things are more important. So one of the other ones that I like that they put in is that you work within the limits of professional knowledge and skills, because that we can go back to that story I told about the person at the conference and the cancer thing, but also when we look at the brand new student that's coming out. So let's just say a student, I graduated in December when I got out of school. So let's just say that I graduated in December of 2022. And then all of a sudden in 2023, I look at that and I go, oh, I don't have to take CECs anymore. Then you should be very limited as to what you can do with your patients.
Yeah.
Right? Like if you're staying within that professional knowledge and skills, when I look back at what I know now compared to when I got out of school,
Oh,
it's light years difference. And I'm not trying to say that I'm some smart person. It's just that I've learned a lot in the last 10 years.
oh yeah.
And the way that I treat is different now. The way I communicate is different now. So I think that's a really important one, because hopefully those students that are coming out brand new aren't going, oh, perfect, they've just told me I don't got to take CECs anymore.
And you would hope that students, like fresh students out of school, would want to learn. And I mean, I think we're a little bit in a bias or a little bit of an echo chamber, at least for me, I can speak for myself, is that a lot of the people that take my courses or sign up for my memberships or to takes of mine are new grads or relatively new grads that want to learn more, that have been exposed to stuff. I would say that you don't get nearly as many of the 20 plus year veterans taking stuff. So, I mean, I could just be me, but that's just my anecdotal experience is a lot of the younger, they're not always young, but new therapists.
Yeah. Younger in the field.
Yeah. Usually younger than me, but, but newer therapists are.
Most people are younger than you and me. So
yeah, that's true. That's true now. Didn't used to be that way.
No.
Are people that want to learn, and a lot of them will take stuff even though there's no CECs involved.
Yeah.
Because like, I want to learn this information. This is important to me. This is important to people I want to help. I want to learn all the things.
Yeah.
So I hope that becomes the kind of common thing. And I hope that when people are finishing school, like the educators at the schools now are kind of planting that seed of basically being like, you're a lifelong learner. You don't need to do CECs, but you still need to learn. Like, it's really important. Find a population or find an area of interest or find, people you want to learn from and take their stuff, because that's going to be valuable.
Yeah.
And like what you said a few minutes ago was that if I think back to how I used to think and how I used to practice and how I used to treat people and how I used to communicate compared to, the last, 7 or 8 years, like, it's embarrassing.
Oh, I've often said I should go back and apologize to most of those people.
Yeah. And I am so surprised sometimes that people still came back but I guess it's just a matter of people had these expectations and you provided that to them and you thought you were helping them. But I think a lot of times I wouldn't say you're always making them worse, but you weren't always helping them.
Yeah.
Right. And I think it is hard to think that way. And you think even too, when you're starting to adapt and trying to be more what you call science-based or evidence-based, and you go through that process, I think you screw up even more because you're trying to change that narrative and you're trying to change how people think. And you're doing stuff and saying things which are really unhelpful and probably quite harmful.
Yeah.
So I think there's a learning process which we all have to go through. And I think anybody that feels that they know it all or feels they don't need to learn anymore, I think that's a dangerous thing.
You should probably leave the profession.
Yeah. I mean, I always want to learn more because I never feel like I know enough.
Yeah.
But that's me. And I would hope that the majority of us would be that way. Be like, yeah, you know what? I would really like to learn more about ABC, whatever this field is or this area is. I want to learn more about, I don't know, sensory neurophysiology, or I want to learn more about, helping geriatric population or seniors. I want to help more with athletics, or I want to help more with chronic pain, or whatever it is you choose you like. I think that people should just like focus on. pursue
Yeah.
that, right? And hopefully my hope would be with this new stuff here, with these new I keep forgetting what they're called,
Guidelines or
career span competencies.
yeah.
Nothing in here talks about techniques,
No.
right? It's not about learning new techniques. It's not about expanding your techniques. It's not about the only thing they say is they take technical knowledge and skills.
Yeah, but at the bottom, but there's nowhere in there that talks about technique.
Yeah, which is, to me, is
Oh, sorry, there does.
brilliant.
It does. It says you apply your knowledge and technical skills, procedures, equipments, devices, techniques, but
Right.
you're gathering skills to gather information, assess, plan, and or deliver services. So even with that, they're not saying that you go out and learn a whole bunch of new techniques. It's that you gather everything that you know and apply it.
Yeah. Yeah, that's right. Yeah, and I read that again, and you're right. It does say technique, but it doesn't talk about gaining new techniques. And so much of what we learn in our profession, we've talked about this before, is that people are looking to always get new techniques all the time, right? Collecting these tools. And there's a certain point where, like, yeah, you want different ways of touching people, but I would say that, majority of what we learn in terms of how to touch people,
yeah,
is we learn in school.
I probably learned everything I need to know about how to touch people in the first 3 terms of school.
Yeah. And it's just a matter of refining that and kind of developing your own kind of, yeah.
The way you like to do it, the way your patients like you to do it.
Yeah, exactly. One other one here I thought was really good. Kind of the next point was, and this is really what should come down to. Now, we've talked about this before about evidence-based versus evidence-informed. I'm not as I initially liked the evidence-informed approach, or that evidence-informed definition, but I've now kind of gone back to, I think I prefer evidence-based.
Sure.
Just because but same idea. Anyway, use an evidence blank approach in your work, right? As they say, you make workplace decisions by integrating the best available evidence relating to the situation at hand, including research and credible published information, your own professional knowledge, including that of trusted colleagues, the patient perspective, and the practice context. So if we're using evidence we really should be using evidence to inform our practice and combining what's the research say, right? So usually when we talk about the stuff and we teach the stuff, right, we usually talk about clinical practice guidelines, which are pretty specifically vague to be able to apply this information to people. But the thing that's interesting with me with this, though, is that if you said to if you said to many people, what's evidence-based practice mean to you, or what's evidence-informed practice mean to you, you're going to not get answers. You're going to get a lot of different answers. And I think the problem is that terminology, or that phrase of evidence-based or evidence-informed, is not really well understood.
No. Even within leaders in the profession, it's not really well understood.
Yeah. And I feel like sometimes we say these things and we're pretty bold statements. We're kind of throwing people under the bus, but not anybody specifically, but you do see that all the time is like, so if something is evidence-based, that means it's based on the best available evidence for that. So let's use cancer, because that seems to be the one. So if you're say your course is evidence-based
treatment for
oncology, evidence-based massage therapy for the oncology patient, there's a course name for you.
Sure.
And how are you deciding what information are you finding that's the evidence for that course? And do you know how to critique that evidence? Do you know how to apply that? Is that evidence good or bad? Right? Are those case studies? Are these clinical practice guidelines? Are these just a single randomized controlled trial? Is it a systematic review with meta-analyses? And then is there maybe some qualitative stuff there, but like, how do people feel that are being treated with cancer? How meaningful or important are these massage appointments for them? Like, there's a lot of different types of evidence that we could use.
And are we applying it individually to each person who comes in? Because that's going to change with each person.
Exactly. So that always, this kind of stuff, I love it. I think it's great. But my skeptical nature of where I'm, I kind of don't really believe in anything. Move a nihilist. I think a bit of a nihilist sometimes. Is I think, okay, this is great, but is this information going to be applied to courses or to workshops or to conferences. I don't know.
Or even if it's not a course, workshop, or conference, let's just say it's a therapist who has that interest and has maybe taken some and now is going, okay, well, now I'm going to look at a bunch of the research on my own.
Yeah.
Are they going to apply it the same way? Right. Maybe it's not even from a course, because part of this is, hey, you should be able to sit down and read a research paper and put in that, yes, I've done this. Are they going to, is that individual going to look and go, okay, how do I apply this to Bob that comes in compared to Mary that comes in, who are both dealing with cancer?
Right.
Different cancers, different expectations, different things all around that, right? So it can come down to that individual basis as well, just not just the course basis.
And that goes back to function in patient-centered manner, which was like one of the earlier points, right? And this thing is, it's interesting, right? So we talk about evidence-informed, evidence-based stuff, and they say here, they say including research and credible published information. Now, this is the problem, right? As a profession, I was told recently that some of the schools have actually got rid of the research section of the course, like of the program. Like there's no more research and statistics section.
Wow.
Because it's time, instructors, you don't need to learn that stuff to pass your board exams.
Well, then how do you write your what did they call it? Not a case history.
Basically you do your case study presentation.
Yeah. How do you write your case study if you don't know how to look at research?
And this is just totally anecdotal. This is what I heard, was they just teach basics of that when they're doing that portion of the program.
Okay.
So I don't know, but the thing is, so if you're not teaching, and this goes back to this goes back to what I did in my graduate studies, was that when you're not teaching people the basics of science, literacy, of research, interpretation, and applications, you're not and you don't teach people about the knowledge translation from research to practice. Like when those basic fundamentals aren't taught, they are never learned.
Yeah.
So our college is saying we need to be evidence informed in our approach. We need to include research and credible published information. But when that information isn't presented to people or taught to people in schools, how are they supposed to learn it? Are they going to go take a course that teaches them how to read and interpret and understand a scientific paper? Not many. So when it feels to me, when I hear this and I read this, I think, yes, this is great. We should be using an evidence-informed approach in our work. But how do we know what's evidence-informed or evidence-based if we're not taught it?
Yeah. You don't know what you don't know.
You don't know what you don't know. And you can learn it. And a lot of us do learn it on our own, but that's a self-regulated thing. So I would almost like to see a 16th point which was like, learn how to do or how to understand research.
But see, therein lies the problem, because like, just to expand on what you're talking about, not only will people likely not come out and want to take the course, they won't know that they should take the course because they've never been taught it. And it goes back to, I don't know if we were talking about it on a podcast or where I was talking about it recently, but we're primed from college to believe that we should constantly take technique courses because we learn more technique courses in school than we do about therapeutic exercise or research or any of those things. So now if the research component isn't even there, but you've been taught 5 technique courses, you're going to come out thinking the best thing I can do to help people is take more technique courses.
Right.
Because that's what's been ingrained in you in school. So not only will people come out and possibly not want to, but they won't think that they need to because there's never been any seed of importance placed on that.
Yeah.
And that's sad.
Yeah.
Because I remember when I did my case study, I got ripped apart because the research I used was terrible.
Yeah.
Which is good because that showed me, hey, you did a shit job on the research end of this, so you need to improve on that.
Yeah.
But now, how could they grade somebody on that if they're not even teaching a research course?
There's big holes in all of this. Yeah. But the idea is good. So hopefully there will be a little more Maybe we can do it. Hopefully there'll be some more updates on this information. Maybe we can do like a follow-up podcast on it
Yeah.
yeah, maybe they explain a bit more detail, right?
Yeah.
Because it also, so yeah, so if the next point, which I thought was great, which is really relevant to all of this, which is practice in a self-reflective manner. You regularly take time to consciously think about your practice and to analyze your decisions and their impact. You obtain feedback from others and you draw on external information to continuously improve your professional capacity and performance. This is very closely related to evidence-informed, evidence-based practice, which is great. So analyze your decisions and their impact. And it's funny, like self-reflection is something that they do not teach routinely in massage schools, at least for the conversations I've had with educators and schools and new grads. But it's something that you see in all higher level university education.
Okay.
Graduate studies, master's, PhD studies, is that self-reflective. So basically, how do you know what you know?
Mm-hmm.
And why do you do what you do? And why do you think the way you think? And why did you make that decision? Why did you say this thing? And really allows you to stop and think about and like your decision making. And when you stop and think about it, sometimes like, why I did this thing, I said this thing because I read it somewhere and I thought it sounded relevant for this person. Maybe that's why. Yeah. Or maybe it's because you read a paper on it, or maybe it's because you're like, I have no idea. This just felt like the right thing. But I think it's really important for us to develop our like say our professional capacity and performance by stopping and thinking and reflecting on our knowledge and why it is we make the decisions we do.
Totally.
And I really like that practice. Like that one for me is one of my favorites from this, and something that I would love it. This is me throwing this out there to the universe. I would love it if there was, if that was something that they started teaching self-reflection in massage school. I think it would drive students crazy because they'd probably have no idea what you're talking, how important it is. But I think it would be really, really important. I know I had to do it when we did in my graduate studies. Like almost everything we did was we had to do these like self-reflective journaling and stuff, which was super annoying at the time. But then once you kind of get into it, you realize how important it is because you're like, oh, that's why I think that way. Or that's why I said this thing.
I just started journaling this week.
Oh, there you go. It's really important. I feel it's really important. And I know I'm not the only one because it seems to be a common theme and common thread. Yeah.
But I think, and this might be a really good way to wrap this podcast up. But if we look at unless there was other points you wanted to make.
No, this is perfect. This has been a good one, I think.
I think if we look at the end of that practice in a self-reflective manner, what it says is you draw on external information to continually improve your professional capacity and performance. So that in itself shows us that it's your responsibility to continually improve, not to look at this and go, oh, we don't have to take CECs anymore. The onus is on you to continually improve and be a professional. Because when we look at the other healthcare professions, especially if we look at doctors, nurses, OTs, physios, chiros, like all these other ones, all of them, they may have the same idea where it's a self-paced thing, but they are required to take continuing education. And our college is putting the responsibility on us to be a professional and to perform in a professional capacity by continuing to upgrade our knowledge and information that we use in our practice.
Yeah, it's very important. And I think if we want to maintain our credibility, if we want to realize our true potential, and we follow these career span competencies, and individual RMTs take it upon themselves to really take charge of what they learn and how they progress as a profession. I think this is a positive direction forward. And like we said, we start off the podcast with is from a business perspective, having the minimum CECs was great, but as a profession, we do know that doesn't really help people.
Yeah.
Because people just take stuff just for the sake of taking stuff. Whereas this is something that's a little more, probably more time consuming if you do it properly, because you have to create a learning plan and you have to engage and you have to reflect and you have to do all all these things and then you have to show how you have met these goals that you've chosen for yourself. And maybe that's courses, maybe that's workshops, maybe that's conferences, maybe that's whatever, however that looks. Yeah. I think it could be better. And I'm going to maintain a healthy level of optimism, but there's going to be definitely have a little bit of skepticism in there as well.
Absolutely. And really, we should have skepticism with everything that we do. So there's nothing wrong with having that healthy level of skepticism. So I think until next time, thanks for listening, and we'll see you on the next podcast.
Thank you.
We hope you enjoyed this podcast. These kind of topics are what we are all about. If you'd like to learn more, go to our websites,
themtdc.com or ericpurvis.com. If you know of any other therapists that could benefit from this, please tell them to subscribe.